My name is Coeckelenbergh, and I work in Port Bruce, and indeed I will be talking about improving patient care by personalizing anesthesia with a focus on the null. Now, I have a few potential conflicts of interest. Please keep this in mind during the talk, and I would like to particularly thank Medtronic for inviting me today. Antinociception is important. Too often, we find ourselves here, like Esther said, with either patients that receive too much antinociception or those that receive not enough and are at risk of developing complications due to this, most notably excessive pain, even chronic pain. Well, we should be here where patients get up quickly after the operation and have a positive outlook on their perioperative care. Now, how is anesthesia monitored today? In a survey we published just last year that focused mainly on European academic centers, we saw that there are considerable differences in perspectives and use of antinociceptive and anesthetic monitoring, despite many clinicians considering it useful to improve outcome. So we find ourselves in a situation of high variability in monitoring anesthesia depth and antinociception, despite it being considered by many to be useful to improve outcome. Why is there such variability? Is it due to differences in experience? Is it due to doubt and evidence? What I would like to do today is to show you the evidence for the null and maybe give you a small push towards increasing your experience with this monitor. Now, nociception can be defined as the detection, transduction, and transmission of a nauseous stimulus that elicits an autonomic response even in unconscious subjects. The response overall is sympathetic stimulation, and it gives us a way to objectively measure actually the patient's response to a nauseous stimulus. Classically, what we use is heart rate and blood pressure, but these signs are not sensitive and specific to antinociception or anesthetic depth. A lot of things can affect it. Over the past couple of decades, several groups have developed very interesting monitors that elegantly look at autonomic response to nociception. Let's focus today on the null. Now, the null ranges from 0 to 100 and is based on the nonlinear combination of nociceptive-related physiological variables. It contains both hemodynamically derived and non-hemodynamically derived indicators of autonomic response. And what it does is it measures autonomic tonus as a surrogate to NAN balance. One of the first studies that came out with the null showed that during nauseous stimuli in anesthetized patients, there was consistently higher sensitivity and specificity for the null when compared to other indicators of nociception. In a similar study published in 2000 in anesthesiology, they showed the same thing. They added the tetanic stimulus, but overall, again, the null index outperformed other indicators of nociception with a higher area under the curve. In Montreal, Philippe Richebit's team had another very interesting study, where this time they looked at the effect of increasing remifentanil concentrations when applying the same nauseous stimulus. So they applied tetanic stimulation, and they looked at how the null index changed when we increased remifentanil concentration. And what happened was extremely important in validating a monitor. The null index noticed this antinociceptive effect, and the signal decreased with increasing remifentanil. They did a similar study where they topped up or didn't top up an epidural, and again, if the epidural is topped up, the null index is lower, indicating again that this monitor detects antinociception. We also looked a little bit at what can happen to the null index when we add another drug. In our study that we undertook in Brussels, we added dexmedetomidine. So both groups had TCI propofol remifentanil anesthesia, and one group received dexmedetomidine, the other one received a placebo. And we found that the null index and the frontal EEG noticed the synergistic effects of dexmedetomidine and allowed us to administer less remifentanil and less propofol. Now, Meyer in 2019, with her colleagues, published a very groundbreaking study, in my opinion, on the null index. Again, they used propofol, remifentanil TCI, guided by the null and the BIS, and they found that you could decrease the amount of remifentanil you administer. So that's already an interesting outcome. But more interestingly, they showed that they decreased the incidence of hypotension, and not just any kind of hypotension, major hypotension with blood pressure below 55 millimeters of mercury. Now, let's go on a small tangent because hypotension is dangerous. Now, I think we can all agree that there is no fixed definition and that probably a personalized threshold for hypotension would be the best goal, but we can all agree that too low a blood pressure is bad. And what is one of the main causes of hypotension in the anesthetized patients? Well, it's the drugs we give. And you can see in a very interesting study, and there are probably hundreds of studies like this, that show that with increasing depth of hypotension and increasing time, patients are at risk of developing acute kidney injury and acute myocardial injury, both of which have been associated, of course, with increased morbidity and mortality. So is NOL a possible solution? Well, perhaps, at least part of the solution, by personalizing antinociception to maintain autonomic tonus. Now, how do we do this? It's simple. You maintain the NOL and target. What Meyer and colleagues did during remifentanil anesthesia was to maintain the NOL between 10 and 25. So what they did is they personalized NOL antinociception, decreased remifentanil, decreased sympatholysis, individualized autonomic tonus, which led to a decreased use of vasopressors and a decreased incidence of hypotension. As you can see, again, this threshold of 55 millimeters of mercury was significant. This threshold that has time after time after time been shown to be linked to increased morbidity. So that's already an important point. But Meyer and her colleagues went even further. They then published a study in the BGA that showed that when you personalized antinociception, fentanyl antinociception with the NOL by giving fentanyl to keep the NOL under 25 and personalized sevoflurane with the BIS, they were able to, in a cohort of laparoscopic and robotic surgery patients that were receiving only opioid-based antinociception with a morphine or pyritramid and acetaminophen transition, they were able to show this very interesting data. Now, the first thing you need to see is that there's really no difference in the mean amounts of fentanyl. And there wasn't, statistically. But there is a big difference in this figure between the two groups. Can you see it? Can you see that the standard deviation here is much smaller than there? What does this mean? We have similar intraoperative needs, but higher standard deviation in the NOR group. What is the potential impact? What they did is they personalized care to include the outliers. In the control group, they almost always gave the same amount. But in the NOR group, patients that didn't need that much fentanyl had less. And those that needed more had more. And what was the consequence? In their study, they showed that patients woke up more comfortably in the NOR group. By targeting outliers, the NOR led to improved postoperative comfort and a better perioperative experience. Now, will personalizing antinociception with the NOR improve outcome? Probably, if it leads to improved hemodynamics and improved patient comfort. But we still need future large outcome studies in homogeneous groups that look for a specific outcome, and thus multi-center randomized controlled trials. Now, I've talked about having a reactive approach with the NOR index, but can we actually predict antinociception? Could we move from reactive to predictive? Well, if we want to ask ourselves this question, we first need to accept that each patient, like Esther said, is different. A response to a nauseous stimulus can vary. So what we need is we need the same stimulus for everyone and assess their reaction. And what better stimulus than tetanic stimulation, which is easily available in every OR because we use it for assessment of neuromuscular blockade. And it has been shown time after time to be safe and to correspond to a standardized nauseous stimulus. So already 3 years ago, our team presented an abstract here in neuroanesthesia that discussed this concept in its initial phases. Our aim was to determine if the response to a standard stimulus can predict optimal antinociception for incision. And the strategy was to analyze the NOR index change to tetanic stimulation. The population was purposefully heterogeneous to include both cardiac and non-cardiac patients, principally thyroid surgery patients, so that we could have a large range of remifentanil effect site concentrations, and the outcome was incision hemodynamic stability, defined for blood pressure as a value within 20% of baseline, and for heart rate, tachycardia was defined as 20% over baseline, and bradycardia as under 40 beats per minute. So patients were under propofol remifentanil TCI anesthesia. We set the remifentanil effect site concentration to 4 and kept the BIS between 40 and 60. We applied the tetanic stimulation and assessed it. If the normal change was greater than 20, we increased the effect site concentration and repeated. If it was less than 20, we decreased the effect site concentration and repeated. What we wanted was to have the lowest effect site concentration for no change over 20. And this is what we used to incise. And we found that, interestingly, heart rate came back to baseline values without any incidence of hypertension. Now, in the non-cardiac group, there were 2 patients that had a slight increase in heart rate, but of these 2 patients, the highest heart rate was 72. Furthermore, we found that there was a linear relationship between the change in NOL and the optimal remifentanil effect site concentration. This is the formula that's slightly rounded up to facilitate its use. So, the change in NOL index has a linear relationship, or more or less linear relationship, with remifentanil requirements and incision. Is there room for improvement? Well, what if we just do one tetanic stimulation? Could we use this linear regression model to give us an idea? So we tried it. We applied again a tetanic stimulation, measured the change in NOL, plugged and chugged the change in NOL into the derived formula, and incised at that effect site concentration. And we found, again, very interesting information. First of all, we found that blood pressure returned to baseline in almost every patient. One patient had an increase of 21.5%. Okay, it's not perfect. We passed the 20% threshold, but it's not huge either. But very interestingly, and this is might be because we rounded up the formula just a little bit, we have heart rate that remains lower than baseline without any incidence of bradycardia. And in cardiac surgery patients, this could be actually cardioprotective. And again, we showed what's been shown time after time after time with the NOL index, that the NOL index has a higher area under the curve than other indicators such as heart rate and blood pressure or even the BIS for detecting nauseous stimuli. Now, can this work during cardiovascular surgery? That's the real question. So we designed a randomized control trial of 48 patients in all. And we had one group that was NOL guided, where we predicted the effect site concentration for incision, and then we titrated based on the NOL. And another group that had antinociception guided by clinical practice. The clinician could increase or decrease anesthesia based on heart rate and blood pressure modifications. Now, what's really important to know, since we had moderate to high-risk patients, we had a goal-directed hemodynamic therapy strategy in place. We wanted to keep the blood pressure and target within 20%, and we kept the stroke volume variation under 13%. So we applied a goal-directed hemodynamic therapy. We guided remifentanil with the NOL, and we found that, again, we can administer less remifentanil when we guide with the NOL. But we also found some other interesting data, which, needs to be thought over quite a bit in its interpretation. But it's very interesting. First of all, the mean arterial pressure was not different between group, contrary to Meyer's anesthesiology study. But again, don't forget, we were administering norepinephrine to maintain blood pressure within 20% from the get-go of baseline values. However, we also have this. We have heart rate that seems to be better controlled in the NOL group. As you can see, the median is lower. They don't have as much increase in heart rate. And the BIS is also more in target. In the control group, there was more overshooting and decrease in BIS. Very interesting, because we administered less remifentanil in the NOR group. So despite administering less remifentanil, heart rate is more tightly controlled, and this is more in target. Why did this occur? Now, this is only a hypothesis, but I think, perhaps, that is because we administered the right amount of remifentanil at the right time. Instead of having to catch up after, for example, nauseous response and increases in heart rate, and then increasing both remifentanil and propofol, which would have led to decreased BIS, we started with a good effect site concentration and were able to maintain anesthesia in a more stable state. Now, does the NOR have limitations? Well, of course, like anything in life, and like all monitors, there are limitations. For example, you can have loss of signal and you have to readjust your finger probe. For example, in this randomized controlled trial, we had about 5% of missing null values in the interventional group. In the control group, which was blinded, we had almost 20%. So you need to keep this in mind when you use it. If the null doesn't say anything, you need to adjust maybe the electrodes, maybe even change them. What about hemodynamic variables? Like I said, one of the main things that the null uses is hemodynamic response. So if you do something like an alveolar recruitment maneuver, and you increase thorax pressure, and you chase blood out of the thorax and modify heart rate, you might have a change in null. Does it mean that the patient needs more remifentanil? No, it just means that we have an acute hemodynamic event. You need to be cognizant of this. And of course, arrhythmia. Arrhythmia, unfortunately, the null, at least today, is not reliable when there is arrhythmia. Now, what are the future directions? Well, again, like I said earlier, prospective randomized controlled trials. And what about integrating nauseous stimuli into the NOR platform? Wouldn't it be nice if the NOR could tell you how much remifentanil you need before the surgeon incises? So in conclusion, I would like you all to go home with the following messages. Despite views and evidence that antinociception monitoring can improve patient care, there is still high variability in clinical implementation. The NOR index is a reliable tool to assess nociception-antinociception balance intraoperatively. Why don't you give it a try? And future studies should continue to investigate the potential of personalizing anesthesia to improve patient care and comfort. Thank you very much.